Thank you for joining us today for our webinar on what is oral immunotherapy. I am Jennifer Gertz, the Executive Director of Food Allergy Canada, and I have with me Dr. Julia Upton. We'd like to thank everyone for attending our webinar today, and we want to just advise you that this will give you a good introduction to oral immunotherapy, and that for specific questions related to your own situation, we would ask to refer you to your allergist. Before we get started, I wanted to note a few housekeeping items. All participants are muted so we can keep the audio clear for the webinar. We will be answering questions after the webinar. Please submit your questions in the chat or question box throughout the webinar. We will try to get to as many of those questions as we can. This webinar will be recorded and shared on foodallergycanada.ca afterwards. Now I'd like to introduce Dr. Julia Upton. Dr. Upton is a Canadian allergist who is on the staff at Toronto SickKids Hospital in the Immunology and Allergy department. She is an assistant professor in the Department of Paediatrics at the University of Toronto and is the section chair of food allergy and anaphylaxis with the Canadian Society of Allergy and Clinical Immunology. Welcome, Dr. Upton.
Great, thank you so much. So it's a pleasure to speak to this audience today. I really appreciate you listening to me, and I hope that I can answer some questions about oral immunotherapy. So I wanted to start just letting you know a little bit about me and oral immunotherapy. I will try to give you a balanced picture of oral immunotherapy. My personal oral immunotherapy experience is entirely within clinical trials, both in industry and company-sponsored, as well as researcher-led. I'm hoping to give some education about oral immunotherapy and explain why there is enthusiasm and why there remains some controversy. For this discussion, we are concentrating on a certain type of food reaction. People can have all sorts of different reactions to foods, such as lactose intolerance or discomfort from greasy foods. These are all food intolerances. Today, we're talking about immune-mediated food reactions. So there's many immune-mediated food reactions as well. Some people can have celiac disease, which is an immune-mediated reaction to gluten, a component of wheat. We're not talking about celiac disease today or those types of reactions. Today, we are concentrating on a specific type of immune-mediated reaction, which is caused by a specific arm of the immune system and mediated predominantly by an antibody in the blood and on the cells called IgE. IgE-mediated reactions are the ones that give the person the risk of severe allergic reactions or anaphylaxis. And the symptoms of IgE-mediated allergy are skin symptoms such as hives or swelling, breathing problems, heart and blood pressure and blood vessel symptoms such as reduced blood pressure, gut symptoms such as vomiting and cramping. And I will note that the gut symptoms are usually with at least one of the skin or respiratory or heart symptoms to be suspicious of IgE-mediated allergy. And epinephrine is the first-line treatment for anaphylaxis. So allergy tests look for the IgE to the food by skin tests or blood tests. And the type of allergy I just described, IgE-mediated allergy, is the type that usually has positive tests. So we can look with these tests to a food to see if a person gets an itchy red bump on the skin, and that bump shows us that the IgE is there. Or we can look in the blood for the IgE antibody specific to the food. We call this specific IgE or food-specific IgE. And some people use an older name for these blood tests that was based on the way they used to be done, called RAS. So allergy tests aren't perfect. A negative allergy test is very good at saying someone is not allergic. It is not perfect, but it is very good. So this is illustrated with a large no allergies and a small allergy. The problem is that a positive test is not very good at saying if someone is allergic. So I have shown this with the no allergy and the allergy being similar in size. Basically, someone with a positive test may be allergic or not. And an allergist considers the symptoms of what happened when eating the food, along with the testing, when coming to an opinion about whether someone is likely to be allergic to a food. So because allergy tests aren't perfect, the oral food challenge is the most accurate way of diagnosing a food allergy. So an oral food challenge is when someone eats a serving size of food under medical supervision over a few hours. So before we get into oral immunotherapy, I thought it was important to highlight just the difference between oral food challenge and OIT. So an oral food challenge is a test. Allergists advise an oral food challenge when we think you have a good chance that you're not allergic, or if we need to prove you are allergic, for example, in a study. Whereas oral immunotherapy to a food is a treatment, and it's for people who are allergic to the food. And it doesn't take place over one day, it's over months and months. So let's talk about the process. So what is OIT? This is an overview of the oral immunotherapy process. A person with a food allergy has an oral food challenge at the beginning to ensure they are actually allergic to the food. As I highlighted, the tests are not the greatest. Then the person is given a small amount of the food to which they are allergic. They eat that amount at home for anywhere from 1 week to 4 weeks in most protocols. Then they return for a medically supervised increase in the dose of food. This process continues of eating the food at home, coming for a medically supervised updose. It's almost like going up steps or rungs on a ladder. The increased dose of food is given in a medically observed setting, and then that dose is eaten at home. This phase is called the dose escalation phase, or the updosing phase. This dose escalation phase can last for about 6 months or more. A person may go up a dose and have a reaction while being medically supervised or when they take the dose at home. If they have a reaction, they need to go down a few steps. Then when the doctor advises, they try to go back up again, and the up doses are medically observed. Eventually, about 80% of people that try this process can reach a top dose, often called a maintenance dose. At this point, we call the person desensitized and in the maintenance phase. The person stays on the maintenance dose for months to years. Sometimes another oral food challenge is performed to see how much a person can now eat without having an allergic reaction. So you can imagine if you're eating this much, they may try more and more and more and see how much you can eat. Then the maintenance dose could be stopped for a few weeks to see if there is what allergists call sustained unresponsiveness, often called SU. So we can think of SU like a remission. Has the allergy gone away for now? The work on sustained unresponsiveness shows that most people in most studies will get their allergy back if the food is stopped for about a month. And I will note that this example, I've used pictures of peanuts, but the same principles apply to other foods. The best studied for oral immunotherapy are milk, eggs, and peanuts. So because most people have the allergy come back if the maintenance dose is stopped, many doctors now just keep the maintenance dose. And here I've shown that with ongoing maintenance. Some reduce the frequency of the dosing down from every day to a few times a week in the ongoing maintenance phase. In some studies and in some allergy offices, there may not be an oral food challenge at the beginning of oral immunotherapy. There may not be an oral food challenge later in oral immunotherapy to see how much the person can now eat. The exact amounts and timing of the starting dose, the up dose, and the maintenance dose can vary. There is not one universal protocol unless it is part of a study. And even in the studies, they have used different protocols, and most have flexibility within them. So some doctors start with very low doses. Some do very gradual up doses. Some are using multiple foods. Some are using a maintenance dose chosen to offer accidental exposure protection. Some are using a maintenance dose chosen to offer the person to eat the food in serving sizes. So to highlight this further, because we received a lot of pre-webinar questions about the specifics of OIT protocols, really every area of this process can vary from one study to another and from one office to another. And the exact regimen can vary within patients at the same office or at the same study because there's flexibility to go down on the doses if there's an allergic reaction. A person may go up a dose, have a reaction, and need to go down a few steps and try again. A person may go down on the dose due to illnesses and then try again. Some people will not be able to continue the protocols due to side effects, and they will stop and go back to avoidance. So these last few slides have illustrated the basics of oral immunotherapy and highlighted that there is study variability, practice variability, and there is room for personalization in many protocols. So that probably feels like a lot of unknowns about oral immunotherapy. I do want to highlight that there are things that most doctors can agree on. Oral immunotherapy increases the amount of food a person with a food allergy can eat. Oral immunotherapy increases the quality of life in some patients and families. Most doctors would describe this as a treatment, and the individual remains allergic to the food, just with a higher amount that triggers their reactions. The allergic reactions on oral immunotherapy decrease over time. They do not go away for most with the dosing of the food. And I think most doctors would agree that oral immunotherapy is currently expensive, time-consuming, and requires significant commitment from the physician, the family, and the allergic person. So what does the physician organization say about oral immunotherapy? Right now, there's no endorsement from the North American Allergy Societies. The Japanese Society of Pediatric Allergy and Clinical Immunology does not recommend OIT as a standardized treatment. However, in contrast, the European Allergy, Asthma, and Clinical Immunology Society, which we call EAACI, says that oral immunotherapy can increase the amount of food an allergic person can eat without having an allergic reaction. And they recommend that oral immunotherapy could be offered, but in research centers and in clinical, and that means non-research centers that have extensive clinical experience with oral immunotherapy, oral food challenges, managing reactions. So the physicians are all looking at the same studies, and it's a natural question to wonder, why don't they agree? And again, to highlight these questions that remain, it's really not clear what's the best way to perform OIT. There are questions about who is the best patient for oral immunotherapy. What dose should we aim for? How long to stay on that maintenance dose? We know the short-term studies say that most people need to remain on oral immunotherapy, but maybe there are groups that don't need to routinely eat the food forever. Really, the biggest question of all is why? Why should we do this at all? What are we achieving? And is it worth the risk? And so let's begin with this big question. To understand oral immunotherapy, it's important to briefly discuss the standard of care for food allergy. There is a dissatisfaction from some people with the standard of care for allergies, which is avoidance. So food allergic reactions generally occur following ingestion. Other routes of exposure, such as skin exposure or inhalation, are unlikely to cause significant reactions. Reactions that appear to occur without a known ingestion are likely through contact with the food and transfer from the allergen from the hands to the mouth or other mucosal surfaces. And therefore, avoidance of ingestion of the allergic food is the most recommended management for food allergy. And of course, carrying epinephrine for when things happen. We can't control absolutely everything, and it's important to have epinephrine available. But avoidance of food allergens, and I don't need to tell this audience, but it requires planning, reading labels, asking questions, making special meals, cooperation, coordination, many other accommodations and processes that non-allergic people do not even need to consider in their lives. So why do OIT? So the idea is that OIT increases the amount of food required to have an allergic reaction. About 80% of people, maybe 90%, depending on the study and depending on where it's offered and which patients they choose, can achieve this. And why would you want to do this? So it might lead you to reduce dietary restrictions, perhaps reduce reactions from accidental exposures because of that daily dosing, maybe reduce anxiety, improve quality of life. So in the process, in the oral immunotherapy process, the person has allergic reactions to the doses of the food eaten for OIT. Not every dose, not every time, but that's the risk of this. So let's think about that. The risk of allergic reactions in food allergy, in avoidance, or oral immunotherapy. So honestly, it's hard to directly compare the accidental exposure risk to the risk of allergic reactions on oral immunotherapy. There is a Canadian peanut study that shows that approximately 13% per year of people with peanut allergy have an accidental exposure. And 66.4% of those reactions were moderate to severe. And there's a very significant underuse of epinephrine in that population. Thankfully, in food allergy, fatalities are very low. In oral immunotherapy, upon eating the oral immunotherapy dose, there's a risk of allergic reaction. And in many series, both in the community practices as well as in the studies, about 10 to 20% have required epinephrine for treatment of a reaction during the updosing of oral immunotherapy. Stomach pain, anxiety, and allergic reactions cause about 15% to stop the oral immunotherapy process. And there have been no reported fatalities. There has been eosinophilic esophagitis reported, as well as food-associated exercise-induced anaphylaxis. And that's a bit of a mouthful, so I'll show you what it is. So exercise, illness, seasonal allergies, other things can reduce the amount of allergic food required to cause an allergic reaction. It's like going down a rung or two or more. When you get sick, the amount that you can eat without having an allergic reaction can decrease. And that's why it's recommended in oral immunotherapy to wait 2 hours after dosing before you do strenuous exercise, and also to reduce doses during illnesses. Eosinophilic esophagitis, which we often call just EOE, has been reported in around less than 3% of people on oral immunotherapy. This is a different kind of food allergy than most of us are familiar with. Cells called eosinophils build up in the esophagus, and this process affects the ability to eat and for children to grow. It makes it difficult to enjoy their food, and food can stick and cause problems and reflux and other gastrointestinal symptoms. It's usually resolved after stopping the food. So some allergists are actually able to go back up on the dosing after some time. And gastrointestinal symptoms are usually the reason that patients need to stop oral immunotherapy. I will note that eosinophilic esophagitis also affects people who never did OIT, people who are treating their allergy with avoidance. And this is a theme when we're comparing avoidance to oral immunotherapy, that many of the same problems are a problem in both groups of people, whether they're avoiding or having OIT, and it makes it difficult to compare. So we've talked a bit about quality of life. And how do you assess quality of life? Standardized questions have been developed to try to assess quality of life, and we know that food allergy very much affects quality of life. Many studies do show an improvement in quality of life with oral immunotherapy. There are patients and families who describe this treatment as life-changing. It has changed the way they approach travel, restaurants, bullying, and just their overall sense of control. I will note that not every family and patient has an increased quality of life. And there's a thought now that maybe the quality of life improvement may be related to the baseline quality of life. So how satisfied or unsatisfied are you with the current management of avoidance? The allergy field is getting better at understanding what do people want. People are different. Not everyone defines success as no allergy at all anymore. Not everyone wants to eat the food in serving sizes. So it really depends on who you are and what's important to you. Some people want to know they have protection from accidental exposures. And I think we need to get better at being able to counsel people to help them decide what's right for them. So what happens in the long term on oral immunotherapy? So we do know that the longer the person is on oral immunotherapy, the longer they can go without eating the food and stay in remission. So we remembered we talked about sustained unresponsiveness. And so in an egg study, people were still getting symptoms. 54.5% of children in years 3 and 4 were still having mild symptoms upon the egg dosing. When they stopped the food, they stopped it once at 2 years and then once after 4 years. After 2 years, 27.5% of the kids achieved sustained unresponsiveness. And so again, that means they didn't react to an egg oral food challenge after not eating egg for 4 to 6 weeks after 2 years of treatment. And 50% achieved sustained unresponsiveness after 4 years of treatment. although they did conclude that ongoing remission really does likely require ongoing ingestion of the food. And we know that if the food is not eaten, the allergy can come back. And we've seen in the longer term studies of following people after oral immunotherapy, some of these people drift back to being allergic. So in an Italian study, 86% of people desensitized to milk fell to 70% over 4.5 years. And in one of the major American studies, only 25% continued to consume milk regularly without symptoms after 5 years of follow-up. And to further understand the long-term effects of OIT, it's helpful to think about the natural history of food allergy. So this is just a simple graph showing that over time, if we follow a group of people where everyone is allergic, some people will outgrow their allergies when they're treated with avoidance. So we need to compare that to the fact that for some food allergies, over time, people are outgrowing the food allergy versus what is oral immunotherapy doing. And you can imagine that if you're studying a food which has a very high rate of being outgrown, like milk or egg in a young child, then this natural history makes it very difficult to make firm conclusions about the ability of oral immunotherapy to treat an allergy or to make an allergy go away. Further complicating this is that the studies usually allow the comparison group, they're treated with a placebo and sometimes an observational group, to go on oral immunotherapy after about a year. So when we talk about studies looking at 2 years out, 4 years out, or longer, usually we no longer have that comparison group to look at. It just makes it more difficult to understand what is the natural history and what is oral immunotherapy actually achieving. So when they looked at a long-term egg study, they found that in follow-up after 4 years, there was no difference in the groups of whether there was any egg ingestion between the active and the placebo-treated participants. And that's because over time, the children that were on avoidance were introducing egg into the diet. And again, that goes back to this idea. You're having this baseline rate of people that are outgrowing the allergy. I will note that very allergic people can develop allergies after avoidance as well. So we've been talking about, okay, if you do oral immunotherapy, maybe you need to stay on the food, but I would like to highlight that even if you never did oral immunotherapy, you can develop allergies by avoidance. So children with bad eczema can develop food allergies from avoidance of foods. And allergists advise children with eczema as best as we can to keep the tolerated foods in the diet. Allergists advise that even after a past oral food challenge, the food is kept in the diet to avoid the allergy coming back. Knowing this, probably some degree of ongoing exposure will be needed for most patients who have done oral immunotherapy. So what is oral immunotherapy doing to the immune system? Overall, the same immune changes are seen in oral immunotherapy as are seen in other types of immunotherapy, for example, shots to pollens or venoms. We'll say, though, the long-term immune effects are still not completely known. We got a lot of pre-webinar questions about who may be good candidates for oral immunotherapy. So from a research point of view, studies very much differ in their inclusion criteria, and a source of information about the current trials can be available on clinicaltrials.gov or from your allergist. A recent article written by doctors in America who practice oral immunotherapy in their offices have offered this advice. So I'm just giving you an idea of what some practicing allergists have said, not that this is the only answer. So they suggest that you strongly consider recommending food oral immunotherapy to people with proven food allergy to peanut, tree nut, or seeds, proven food allergy to milk, egg, or wheat, greater than 7 years old. We'll talk about the age in a second. A recent history of IgE-mediated reaction with positive allergy testing, or a remote history of IgE-mediated reaction with very strong positive allergy tests. They suggest to consider or carefully weigh the option if you have positive oral food challenges to milk, egg, and wheat less than 8 years old, because there's this risk of spontaneous resolution, that the child might outgrow it and may not need this process. If a child or a person has never eaten the food and they have positive allergy tests, then this group is recommending to discuss the possibility of false positive testing, like we talked about at the beginning of the webinar, and consider the risks of oral food challenge rather than going straight into OIT. And if someone has never eaten the food and the tests are just small, then really an oral food challenge is essential according to this group. And they suggest some people who may not be good candidates for oral immunotherapy. And they suggest that a history of non-compliance or non-adherence with treatment, parental conflict about OIT, eosinophilic esophagitis, and then the other non-EOE eosinophilic gastroenteropathies. So in the same way the eosinophils can go into the esophagus, the eosinophils can also go into the other parts of the gut. And other allergic diseases that are not well controlled, such as asthma. It's really essential whether there's a management strategy of avoidance or oral immunotherapy for asthma to be very, very, very carefully managed for people with food allergy. I will note that you may have noticed on those that oral immunotherapy is not excluded for the very allergic. So studies and clinical offices have performed OIT for people that have had a history of anaphylaxis. Not every study and not every office, of course, but it has been done. So what are the predictors of success for OIT? So by tests of the immune system, the lowest risk patients seem to be the most likely to be successful. I've highlighted one study here, but it's a common theme that smaller skin test results and lower allergy blood tests are predictive of a more successful outcome. And in another study, again, just highlighted here that the fancy immunological tests, if you want to think of them like that, the research or advanced immunological testing shows the same trend. So what do we even mean by success? I mean, success can mean completing the protocol. Success can mean making it to maintenance. Success can mean achieving sustained unresponsiveness. All of them tend to have this same finding, that the lower tests are more predictive of success. So I hope that I've shown that overall oral immunotherapy is a treatment that will likely need to be continued. Some people really do require the food to remain in their diet, and if they stop the food, they become allergic. And there's no convincing evidence that oral immunotherapy can influence the natural history of egg or milk allergy. Because so many children outgrow these allergies, it's difficult to compare. But what about very young children? And I thank the audience. We got a lot of really great questions about very young children. So the DEVIL study, which is determining the efficacy and value of immunotherapy on the likelihood of peanut tolerance, is very exciting. So this is a study where they enrolled newly diagnosed children with peanut allergy that were 9 to 36 months of age. And they found that 86% achieved desensitization. And you remember that sort of making it through the OIT protocol. And 78% had sustained unresponsiveness or remission after 3 years of treatment. And importantly and excitingly, when they followed the blood work, this stopped the rise in IgE, the allergic antibody that we often see in allergic children. So should OIT be done in very young children? One of the things we always have to think about with very young children is they don't make their own decisions. Someone has to make decisions for them. And therefore, the standard is often that the degree of risk must be related to the degree of benefit. And the evidence to offer a treatment to young children often requires a high level of evidence that it's helpful to them. So there is a study that's looking at this exact question. Is OIT, a real cure, if you want to think of it that way, in young kids? And it's called the IMPACT study. So the IMPACT study has two goals. It's using peanut oral immunotherapy. It wants to see if it will lower the risk of allergic reactions, and also to determine whether this therapy can change the immune response, so that even after an immune therapy is stopped for a long period of time, and in this study they're going to stop it for 6 months, that symptoms of peanut allergy do not recur. So what about older children and adults? So there's fewer studies in adults than children. There is evidence for increasing the amount of food a person can eat without having an allergic reaction for adults as well and older children. And the EACI concluded, remember the EACI is the one that does have the position statement or guidelines that is supportive of oral immunotherapy in limited settings. The EACI concluded that there was no strong evidence, sorry about the slide there, but there was not strong evidence to use oral immunotherapy in adults. So should someone do oral immunotherapy? So some reasons to say yes. So quality of life issues such as social exclusion, anxiety. Some people want to take an active role. Some people really want accidental exposure protection. There's the risk of allergic reactions on oral immunotherapy do decrease over time. They find avoidance very difficult. There's considerations of which food, knowing that the food probably needs to be kept in the diet. Some foods are more amenable to this. And we hear people say, well, what if it's a cure? And I think you might need to think about, what does a cure mean to you? So reasons to say no or not yet might be that the risk of allergic reaction on treatment still requires carrying epinephrine and readiness to use it, which really can be one of the greatest sources of stress for people on avoidance. It requires management of doses and sickness and exercise. The markers of success are all the low allergy numbers, and so that does bring concerns that perhaps oral immunotherapy is not working as well for the people at the highest risk of reactions and of not outgrowing. Oral immunotherapy has this ongoing need to eat the food, and there's a concern that avoidance skills could be reduced in people because they're still allergic, just with a higher amount that makes them react. And possibly they may need to go back to using their avoidance skills at some time. There's a cost issue, so both money and time, accessibility challenges. It's not clear that it improves quality of life for everyone, and some people say to wait for the studies. There are many ongoing studies looking at trying to either improve the process or exactly trying to understand the best way to use it. So I wanted to put some thoughts on oral immunotherapy that I think do get across the level of commitment that are needed. This is from a pro-con debate at one of the American allergy societies, and this is the person arguing that OIT should be used and that OIT is helpful to the patients. And he says we're doing more than just desensitizing the patient. We're reminding them every day they have a peanut allergy, which is something not found in the avoidance management strategy. Every day they are checking where their adrenaline kit is. This does not happen often in the avoidance management strategy. We're selecting our patients and our parents according to those who we think will succeed. This doesn't happen with the other group. It just, when you read that, you do wonder about the role of education. Families on oral immunotherapy are seeing a medical provider anywhere from every week to 2 weeks to maybe every month. And you wonder if a comparison between oral immunotherapy and a strategy of support and allergy readiness and education and asthma management, might achieve some of the same empowerment that oral immunotherapy can provide. Those are just thoughts. So why is oral immunotherapy not practiced on a large scale in Canada? I think it's a surprise to most people to know there's less than 250 Royal College allergists across the country. So it's really, we are struggling with how will we offer a treatment requiring multiple visits, significant education and after-hours support in a fair and equitable way in socialized medicine. And cost is not formally covered under provincial plans. And it's for those who have perhaps more experience with other countries, Canadian physicians typically do not solicit patients or advertise. We're learning more and more about oral immunotherapy. So actually the first case was reported in 1908 in the Lancet, and they successfully desensitized a 13-year-old boy with egg allergy. So that's a long time ago. But in the last 5 to 10 years, there's been a really big change in the motivation. When these studies were starting, people thought it would be a cure. Now it's more of a thought of sustained unresponsiveness and quality of life, which are definitely important. There's been a huge recognition of the importance of managing cofactors, the need to dose on a full stomach, to separate exercise, to reduce doses during infections, and managing the asthma so carefully. In most studies in 2018, the dosing targets or the maintenance targets have been reduced. And we understand that most people on this process are still allergic. So will there be any other choices? So hopefully there will be oral immunotherapy protocol improvements, although it is a very flexible process depending on who your provider is. There are studies ongoing with sublingual immunotherapy where they use much smaller doses just underneath the tongue. There's anti-IgE therapy, so that's a medication that can block that allergy antibody. And it's being looked at for both oral immunotherapy or without, just to increase the threshold of reaction. So meaning increase the amount that someone can eat without having an allergic reaction. There's many other investigational products. And then there's also on the avoidance side, efforts to better understand who really needs to avoid tiny exposures. Because right now in the avoidance management strategy, pretty much everyone is treated as if they're extremely high risk. And so there are efforts on that side as well to try to really understand who's really at the very high risk, who needs to be as careful as that, and are there people that maybe could relax some of these restrictions, and perhaps that would reduce anxiety and help quality of life as well. So just some thoughts, that you might want to consider if you're considering oral immunotherapy, that you'd probably want to think about your goals of therapy. Is it eating the food versus accidental exposure protection? And do your goals align with what the physician in the clinic or in the study can offer? Is there after-hour support? Do you have commitment to a long-term active process? And I think the education side is really important in terms of asthma control, in terms of recognizing symptoms of an allergic reaction, being very comfortable with epinephrine treatment, recognizing times when dosing needs to be decreased or when to touch base with the physician, and this separation of exercise and dosing. And those are just a few thoughts, as well as the family support. We have found, that sometimes the extended family is very supportive, and sometimes they can be quite confused by this process of an allergic person eating the food they're allergic to. As simply as possible, I think the avoidance strategy is an actively avoid strategy, and oral immunotherapy is an actively eat strategy. Both need support, both need education, and I think people will differ on what they think is best for them. I wanted to highlight some similarities. So if we think of a feature of food allergy and then think about it in avoidance, and we think about it in oral immunotherapy. So both groups need to carry the epinephrine autoinjector. Both are expected to use epinephrine for acute reactions. Both need to think about the allergy every day. Some people call that the daily burden of vigilance. For the avoidance strategy, it's thinking of all those ways that they need to avoid the food. And in the oral immunotherapy, they need to think about how to take the dose and how to separate it, and are they sick, and is their asthma under control. Both need to be knowledgeable about allergic reactions. Controlling asthma is a top priority for both. Both have a risk of eosinophilic esophagitis. It may be higher in oral immunotherapy, but that's not clear. As far as cure, some people outgrow on an avoidance strategy, and in oral immunotherapy, some have sustained unresponsiveness. And what about the allergy returning? We do see that even after passing an oral food challenge after avoidance, that if you have a prolonged period of avoidance again, then you can have an allergic reaction to previously tolerated foods. And then on oral immunotherapy, if you avoid the foods after completing the updosing or maintenance of oral immunotherapy, you can result in the return of allergy in many or most. So some of the differences. In the active oral immunotherapy strategy, people come to the clinic quite frequently, which differs quite a bit from the once a year or maybe twice a year that people see their allergist for in avoidance, or even less sometimes. People in the avoidance strategy certainly need to read labels to avoid the included allergen. I put that in brackets for oral immunotherapy because, as I hopefully got across, some oral immunotherapy strategies actually have a goal of you being able to incorporate the food. Others are trying to protect you from accidental exposure. And so that will differ depending on the exact regimen that was used. In terms of avoiding trace or may contain, and this really, could be 20 slides on its own about restaurant concerns, travel, bringing your own food, sharing food, etc. Clearly that's more on the avoidance side. For food-associated exercise-induced anaphylaxis, in the oral immunotherapy group, they need to think about this 2 hours without strenuous activity every dosing day and have 2 hours without strenuous activity every dosing day, maybe even into maintenance. Again, that will depend. In the oral immunotherapy group, they can react to a dose of food that they used to eat. And so the idea that someone could be able to eat, for example, 20 mils of milk on Monday, 20 mils of milk on Tuesday, 20 mils of milk on Wednesday, and then anaphylax to that same amount on on Thursday can be quite stressful to people. There's the fear of accidental exposure reactions, and that is in the avoidance group. And then this idea that you might lose practice with avoidance skills in oral immunotherapy. And I'm not suggesting I've caught every similarity or every difference. So these are just some things to think about and a way to compare and contrast the two strategies. So I really hope I've provided some education about oral immunotherapy. I hope I've helped explain why there is so much enthusiasm and why some of these controversies still remain. I thank you so much to Food Allergy Canada, and I really thank you for listening, and I'm looking forward to answering questions.
Thank you, Dr. Upton. That was a great informative presentation on oral immunotherapy, and there were a lot of questions that came in during the presentation. Before we get started on those questions, we did receive quite a few questions about where to get oral immunotherapy, and we would ask you to speak to your allergist to find out if oral immunotherapy is right for you and where it may be available. So let's move on to our first question. This one is, there were a number of questions around multiple food allergies. So with a child that has multiple food allergies, how would OIT work for them?
Great, thank you for your question. So multiple food OIT has been used in some centers and was pioneered at Stanford, and there are some other places. So the foods are all eaten together. So instead of having just a little bit of milk or a little bit of peanut, you take all of the foods that you're allergic to at once. The benefit of this is that all of the foods can be desensitized at the same time rather than one after another, which is why they wanted to explore the possibility of doing the multiple foods. Certainly this has limited availability currently and is something that I think both the researchers and clinicians hope can be further refined in the future.
And similar to that, that line of questioning, one of the questions that came forward was, why does the OIT conversation tend to focus largely on peanut?
Great, thanks for that. I know even I am guilty of using a peanut icon in the initial slides. I do hope that I got across that the studies on oral immunotherapy have been predominantly in peanut as well as milk and egg. I think that when you're quoting about studies for oral immunotherapy, it is helpful to use the peanut ones because peanut is outgrown at a much lower rate than milk or egg. And so if we think back to that natural history slide, milk and egg allergy are commonly outgrown, often estimated at greater than 85%, whereas peanut has a reported rate of outgrowing of less than 20%. So certainly in the initial studies when people were trying to see, does this work or not? Does this have any, should it be pursued? Should it be explored? The peanut studies are more convincing for that. And you can also imagine that the number of people you would require to show differences are going to be less in a peanut study than there would be in an egg or a milk study. So certainly I agree that often even all food allergy conversations center around peanut often, but actually in oral immunotherapy, the data is strongest for peanut, milk, and egg.
Great. Thank you for that clarification. The next question we have is, what do you do if your allergist is telling you to start OIT at home with your anaphylactic child? Is it safe to do this at home?
So I would not recommend home oral immunotherapy. I will say sometimes we find there's a miscommunication and confusion over the different terms in allergy, and that's why I started this presentation with comparing and contrasting an oral food challenge to oral immunotherapy. So in our experience, sometimes home introduction, oral food challenges, oral immunotherapy, early introduction, all of these things can be confused, and it makes sense. You know, you're talking about feeding food, sometimes medically supervised. The terms can be confusing. So I would really suggest that that person seeks further clarifications from their doctor, and I would not recommend home OIT.
So typically, Dr. Upton, when someone says home introduction, what would that generally refer to?
So generally, a home introduction would be when the allergist believes the person is not allergic to the food. And that's why I would definitely recommend that this family seeks clarification rather than oral immunotherapy, which is a treatment for people who are allergic to the food.
Great, thanks for that clarification. Next, we had a few listeners ask about anxiety and how anxiety of the child affects the OIT process. Can you give us some perspective on that?
Yes, thank you. I mean, one of the reasons we want to do OIT is to help that anxiety. But when we look at the studies, anxiety is a reason that some children will not continue the oral immunotherapy process. And some children find it very, very difficult to start deliberately eating a food that they were told to avoid. And some of them take quite a lot of ownership over avoiding that food and also really don't like the taste. Certainly in research studies, children over about 6 or so are given an age-appropriate explanation of the study, and if they don't want to do it, then they do not do it. So extrapolating that, I would think that it may help to engage the child in decision-making and their goals. We find that some kids are just so excited to just be there for pizza day when they've been scared of cross-contamination, or they're excited to go to birthday parties, or some that are now allowed to eat certain foods are very excited for those particular foods. So I think engaging the child in decision making and the goals can be helpful. And in the OIT process, there is a lot of medical contact, and so hopefully that is a time to ask questions and clarifications and seek education from the team.
Yeah, well, it sounds like a lot of communication and engagement from the child's perspective is what you've experienced to help them feel comfortable. Further to that previous question, a few people have asked, what are the challenges faced by children and teens while going through OIT and after, and how can we support them during this time?
Great, thank you for your question. First, I would just touch base that I would want to be cautious about thinking about after oral immunotherapy, or the idea of being after OIT, because the way OIT is currently understood, there's an updosing phase and then a maintenance phase, which really we should think about as long-term, thinking about years. So it's probably, if you go into OIT, you might want to think of it as that's your strategy now. So again, I think similar to the younger children, OIT really typically involves intensive education and very frequent medical attention. And I hope that the teens can use this time to ask the questions and again, shared decision making, taking into account their goals, because it really is an active process that I think in order to do it and to stick to it, they would want to see in what way does it benefit them.
Great. Now, we had a couple of questions around, or a question with regards to the children in the DEVIL study. And the question that you mentioned that there's low-risk patients have had the most success with OIT, but that in the DEVIL study, were the patients there among the lowest risk patients?
Great, thank you. So when I mention the low risk, what I'm saying is when they look overall at the studies, who does the best, the predictors of success, both in the studies as well as in the clinical experience that has come from the US, is that it's the patients with the lowest testing that tend to do the best. And yes, they did see that as well in that study, that the people with the smallest tests, the people with the lowest IgE numbers are the ones that tend to to have the success outcomes, such as sustained unresponsiveness. So, but having said that, there are other studies that say that the labs and the numbers are not as great at predicting who will be successful and who won't. But when they do show a difference, they tend to show those numbers of the lower skin tests, the lower blood tests. So whether that exactly corresponds to severity is probably a topic for a different webinar, but there is a concern that because the kids that tend to do the best on oral immunotherapy are the kids with the lowest numbers, there's this lingering concern of, are we treating the kids that are at the highest risk of not outgrowing? Are we treating the kids that are at the highest risk of the very rare fatal reactions from on the avoidance strategy? Are those the ones that are doing well on oral immunotherapy? And we just don't know that. And that's one of the reasons that this remains controversial, that we're not absolutely sure that we're helping the ones that perhaps need it the most.
Okay, thank you, Dr. Upton. Now, one more question related to the DEVIL study. Did the DEVIL study show kids completely outgrowing the allergy?
I mean, that's an excellent question. So again, in allergy, we're being cautious in using this term sustained unresponsiveness, because to say it's completely outgrown, we don't know that. So that's why people are using that term sustained unresponsiveness, which basically is saying if we stop the food for 4 to 6 weeks and then do another oral food challenge, do you pass that oral food challenge? Because if you passed it after stopping peanut for 4 weeks, would you pass it if we stopped peanut for 3 months? Would you pass it if we stopped peanut for 6 months? So we don't know the answer to that. We only know if you passed the oral food challenge, if you stopped it for whatever the time period was in the study. So they don't use that term of a cure. They use the term sustained unresponsiveness. And again, therein lies some of the challenges in interpreting the literature, because you could always ask the question, well, what if you stopped it for longer? Would the allergy come back? So all we can say is that the outcomes of that study were very good. I mean, a lot of people achieved sustained unresponsiveness. Is that a cure? That's what the impact study is trying to look at. If you actually stop it for 6 months, do you see a difference in the groups? And so the DEVIL study is very exciting, and the work from that led to wanting to look further, and that's why they're doing the impact.
Great, thank you. The last question we have time for today is around safety. Now, I know you talked about some comments throughout your presentation that related to safety, but maybe you could summarize for the audience, how safe is oral immunotherapy?
Great, thank you. Another very challenging one. Thank you, I appreciate it. So medical safety is about adverse reactions and side effects. And so when you're looking at, is something safe, the question is safe compared to what? And so adverse reactions in oral immunotherapy cause 10 to 20% of patients to stop the treatment before they reach the maintenance dose. And about 10 to 20% of patients will have an allergic reaction that they treat with epinephrine during the updosing or the dose escalation phase. And almost everyone on oral immunotherapy will have mild allergic symptoms with some of the doses. And these will continue even 3-4 years out. We see in the egg study that people are still more than half of people are having reactions to their doses. So the safety of a treatment, though, needs to be considered in the context of the whole disease. And what is the benefit of the treatment? What are the risks of the food allergy treated with avoidance? And this is really where the controversy and debate comes down to. Is OIT safer than avoidance? And so you can imagine there's so many factors that make this answer change, depending on the person, depending on compliance with avoidance, compliance with oral immunotherapy, other allergic problems such as asthma, the nature of the food itself. If you do OIT, how easy is it to continue the food? And so many other factors. So really there isn't a simple answer to answer, is it safe? Because the question is it safe versus avoidance? And I hope I gave information today to help people see where these uncertainties lie, and also for people to think about, in these different strategies, what can they achieve and what's important to them.
Great. Well, thank you, Dr. Upton. You've given our audience lots to think about and enlightened us on the path to oral immunotherapy and the things that we should be thinking about. We would like to take a moment to thank our sponsors for the ongoing webinar series, Pfizer Canada, Sean Delaney Memorial Golf Classic, the Walter and Maria Schroeder Foundation, and the Peanut Bureau of Canada. We'd also like you to consider a donation to Food Allergy Canada. We are a national registered charity, and we rely on our donations in order to support the food allergy community, like with these ongoing informative and educational webinars. We would be grateful for your support. Please visit foodallergycanada.ca/donate to learn more about the impact your donations will make. Thank you very much for your participation in this webinar. We hope that you found the information helpful and useful. There will be a short survey that you will receive through GoToWebinar immediately following this webinar. It will pop up on your screen, and you'll also receive a survey via email in the next hour or so. Please take a moment to complete it. As a reminder, this webinar will be available as a recorded version on foodallergycanada.ca in the coming days. Thank you. This now concludes our webinar.